The use of omacetaxine in combination with tyrosine kinase inhibitors early in the disease is not a common practice, because the reason is because most of the tyrosine kinase inhibitors are really effective in the front line or even the second line. However, in more advanced phases of the disease, such as accelerated phase or even after multiple failures, there is no really specific data about that, but in an anecdotal way it's been described in the literature, and I have my own experience to really combine these two drugs. However, once again, there is not really a very common form of therapy, nor really there is a clinical trial that supports this management. There is no specific rationale to combine tyrosine kinase inhibitor with omacetaxine. However, there is anecdotal data published in the literature in form of case report and even my own experience, where in certain instances where there is no other alternatives of therapy, or the TKIs are not really good enough to control the disease, combination of these two forms of therapies, tyrosine kinase and omacetaxine, has shown some benefits for patients. Once again, there is no formal clinical trial conducted, but there is anecdotal experience in the literature and in my own practice.
The combination of omacetaxine with a TKI earlier in the phase of treatment is an interesting question. I have not personally used that, but I'm aware of reports where the combination of a second-generation TKI, such as nilotinib, led to more effective hematologic response and eventually disappearance of the BCR-ABL transcript when combining omacetaxine with nilotinib. In that particular case report, the investigator noted that the patient had the T315I mutation, which disappeared very promptly after omacetaxine induction therapy, suggesting that in this case the omacetaxine was very effective at deleting or removing this very hard to treat mutation. And later on, because the patients failed to attain a hematologic response, the nilotinib was added to the continued omacetaxine treatment, and the combination of both led to complete hematologic remission as well as disappearance of the T315I clone. The rationale for combining omacetaxine with a second-generation tyrosine kinase inhibitor, especially in patients who are resistant to imatinib, is a very interesting one. Because it's well known that those patients who fail to respond to first-generation imatinib mesylate can have the potential of having reduced survival and higher incidence of blast crisis transformation. It's also well known that the combination leads to more efficacy of the RNA inhibitor, because the TKI, in this case nilotinib, or even the imatinib before it, opens up the RNA and allows the omacetaxine to be more effective. So you're getting both a synergy from the standpoint of translation inhibitor. So even if the second generation TKI is not totally active by itself in these patients who have failed to respond to imatinib mesylate, the combination still remains a more powerful tool, and obviously is an area that should be studied further.
The use of omacetaxine to deepen the molecular response of patient under TKI is a subject of investigation. However, it's a very tough area of investigation, because most of these patients, even they don't really have reached very deep levels of response, they're really tolerating the drugs and they're doing relatively well. So the introduction of a subcutaneous therapy in this form, in this way, chemotherapy in a subcutaneous administration, is a really hard decision for patients and doctors to make. So it still is an research questions that is not being validated in any clinical trial.
The question is aimed at defining whether rechallenging with the second generation TKI is a useful action. after treatment with omacetaxine in patients who have T315I mutation. I would quickly point out that most practitioners would use ponatinib, which is FDA approved for this mutation and is quite active. So in the case of the patient that we discussed earlier, that patient had developed endocarditis, which was related to his accelerated phase CML, and had arterial thrombi. So I was very hesitant to use ponatinib, which has severe cardiovascular and thrombotic side effects. So in that case, the use of omacetaxine with imatinib mesylate or another TKI becomes a very rational endeavor and a more effective one. Whether or not this will lead to complete molecular remission and durable responses is unknown at this time.